I'm sure you all know Dr. Kozuch is one of our associate program directors for the Hem/Onc Fellowship at Mount Sinai, but he's also the site director for the Division of Hematology and Medical Oncology at BI and West. Thank you again, Dr. Kozuch, for being with us today. We can see your slides if you would want to go back to the initial one. I think it looks great.
Okay. And everybody can hear me okay?
We can.
Okay, super. So we are going, I like to keep things as interactive as possible. So I'll ask the chiefs to also, as we go through questions, maybe they can call on some people to offer answers and their thoughts about why their answers are correct. This is going to be about GI oncology, but I really want it to be applicable to your daily practice as internists, as future cardiologists, pulmonologists, infectious disease doctors, primary care physicians, oncologists, etc. So with that, let's just start with a little bit of didactics, just so we can be on the same page as we embark on what I think are some pretty relevant mix-up questions. And the mix-ups really are near and dear to my heart. I think reviewing them on as much as I could on a regular basis as a resident made me a better house officer. And by the time I was ready to take the IM boards, it really, by the time I was done reading the question, I already knew this is the learning objective. And not only do I know the learning objective, but I thought I had a pretty good handle on what the answers would be. Okay, so nomenclature. I just want to get this clear. The anus is, if people have anal cancer, it is almost always going to be a squamous cell or squamous cell carcinoma variant. The risk factors are being immunocompromised because of you're receiving medications that immunocompromise you for connective tissue disorders, colitis, you've received a solid organ transplant, a bone marrow transplant, HIV co-infection, and potentially receiving anoreceptive intercourse. Presenting symptoms can just be itchiness, pain, bleeding, a palpable mass. We will begin to screen using anal pap smears for anal cancer for people at risk. Early intervention of dysplasia decreases the possibility of developing invasive cancer. That's part of the Anchor study. The results were published in abstract form, just in press release form this past October or November. But anal cancer for the boards and for your daily lives, if you have a person at risk, anal pap smears are recommended. If there's an abnormality, just like cervical cancer, if there's if there's dysplasia, then the patient will need high resolution anoscopy. You can think of it just as colposcopy, but for the anus. And then areas of dysplasia may need fulguration or some other locally destructive therapy. Rectal cancer and colon cancer are always adenocarcinomas. The important difference is that rectal cancer is often treated with chemotherapy and chemoradiation before surgery. And increasingly, we are realizing that in selected patients, we may be able to manage stage 2 and 3 patients without surgery. That's, I think, not yet a board question, but just so you're aware. Please understand that rectal cancer and left-sided colon cancers are epidemic among people younger than 50. The screening age has changed down to 45. Any sort of screening is better than no screening. Colonoscopy obviously offers the advantage of identifying advanced or precancerous polyps, and we can remove those polyps at the time of colonoscopy. A diagnostic colonoscopy is totally different. If you hear that a patient is having bleeding, it's bleeding, and they need a colonoscopy. They think, oh, I'm having a little change in bowel habit, maybe some diarrhea, some constipation. Just put it in the form of a board question. that is a change in bowel habit, or that is blood, and a diagnostic colonoscopy is in order. So rectal cancer, if it's not diagnosed on screening, it almost always is associated with bloody stools. Patients may also say that they're having more fragmented stools. The classic pencil-thin stools, as many things that are classic, that actual presentation is pretty darn rare. It's usually fragmented stools, but almost always 95% of rectal cancer are associated with bleeding. And if it's within 12 centimeters from the anal verge, and the anal verge is where the non-pigmented skin of the gluteal cleft becomes the hyperpigmented skin of the anal verge. And then colon cancer is completely above the tumor. The entire tumor, regional lymphadenopathy, is completely above the peritoneal reflection. The distal end of these tumors are 13, 14 or more centimeters above the anal verge. And that's very important. If it's higher or more proximal than 13 or 14 centimeters, we can go to surgery straight away. These patients, if it's a right-sided tumor, may often present with anemia. So a hemoglobin of 11 is not normal. Fatigue, a small bowel obstruction at the level of the ileocecal valve is not so unusual. Left-sided tumors, that's where the stool's already semi-solid, so patients may have cramps, large bowel obstruction, bloody stools, or fragmented stools. I think it's important to be somewhat aware of the pattern of staging. All squamous cell carcinomas, whether it's of the anus or the head and neck or the cervix, or the esophagus, they love to have vertical growth. Circumferential growth around the lumen of the anus is certainly possible, but anal cancers can sort of trend right up into the rectum, sometimes 5 centimeters, 10 centimeters. There can be submucosal skip metastases, so vertical growth, not just along the primary site, so intraluminally, but also the regional lymph nodes can also be affected. Now, very distal anal cancers can go to the inguinal lymph nodes, staging CT PET and a pelvic MRI. So squamous cell, CT PET, again, just to be holistic here, anus or esophagus, PET scans are reasonable. This may or may not come up on board questions, and certainly in real life. Rectal cancer, we need to understand the depth of penetration of the tumor with regard to the different layers of the rectal wall, and whether or not it's the tumor starting to invade into local organs such as the bones of the pelvis, the bladder, the vagina, the prostate, seminal vesicles. That's very important for our preoperative treatment decisions and even operative planning. Rectal cancer can go right up the retroperitoneal lymph nodes, and it also can, there can be lung-only metastases, probably more so than with colon cancer. Colon cancer, again, it's more of a circumferential growth around the colon. There can be regional invasion by direct tumor extension, by regional nodal spread, all the way up to the superior mesenteric artery, which supplies, the superior mesenteric artery basically provides all the blood from the stomach to the last part of the colon. So very, very important artery. And then, of course, you can get spread to the liver, lungs, peritoneum, bone. What you don't see in any of these tumors is spread to the brain. It is very, very rare. It certainly can happen. Not as an initial part of diagnosis. This is very different than lung cancer, where some patients may present with neurological symptoms because of new brain metastases or seizures. Such a presentation with any GI malignancy, a brain first metastasis as a presenting symptom is just exceptionally rare. This may happen late in the metastatic course. And again, as preparation for your life, Anal cancer, stages 1 through 3, we can cure non-operatively. Squamous cell carcinomas tend to be more sensitive to chemoradiation than adenocarcinomas. Many squamous cell carcinomas of the head and neck, 50%, and the anus, 95%, are associated with a virus, human HPV viruses, of which there are thousands, but the vast majority of HPV viruses are not carcinogenic, but they do make tumors much more sensitive to chemoradiation. Hopefully, we will be able to cure earlier, smaller tumors, 2 centimeters or less, 3 centimeters or less, with lower doses of radiation. That's a trial that we're part of within the Sinai system. And then the higher risk anal cancers might need more therapy, higher doses of radiation, and then consolidation therapy with nivolumab. But the established is chemoradiation with capecitabine and mitomycin. Colon cancer, stages 1 through 3, resection, 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 and then higher risk disease, certainly node positive disease, we treat with chemotherapy. Please, everybody, stay tuned, because I'm going to be dropping some revolutionary technology on you that hopefully is going to make you less pessimistic about adjuvant therapy, because I will readily admit we overtreat some patients and we undertreat others based on technology. The staging technology that we've just been going through is many decades old. We can do better, and I will show you through the wonders of ctDNA that we are going to be doing better, and it's pretty spectacular what you will all be stepping into as oncologists and oncology adjacent practitioners. And there's just been an explosion of advances throughout oncology. Colon cancer is no exception. I think we've kind of hit the ceiling. I'm not going to say there won't be any new cytotoxic chemotherapies, but we sort of have hit a ceiling, and targeted therapies have gotten us to a point where median survival now for left-sided colon cancer that does not have a KRAS or BRAF mutation and cannot be operated on, median survivals are approaching 3 years. Patients with metastatic disease that is microsatellite unstable, I don't know what the median survival will be. I think it'll be well over 3 years. I think it'll be approaching 4 or 5 years. We just don't yet know. And then adjuvant therapy, we will really be able to refine what we do based on ctDNA. So, and again, just conceptually, this is what we do in oncology. We identify single agents that might have efficacy. We will work to potentially combine them to see if we can better palliate patients with stage 4 disease or inoperable disease. We'll work out optimal sequences. We'll begin to combine chemotherapy with targeted agents, all along developing predictive biomarkers, all with the goal of extending survival and minimizing side effects, and thereby optimizing quality of life as well. If we're getting very robust signals in the stage 4 laboratory, we will introduce it in the adjuvant setting, which and adjuvant proof really, for the most part, proof of efficacy needs to happen in a stage 3 environment. Can we proceed with questions? Okay. 74-year-old man, 4 months of increasing fatigue and exertional dyspnea. On physical exam, vital signs are normal, so he's not having a hypertensive urgency, which certainly could cause these symptoms. Remainder of physical exam is unremarkable. Laboratory studies, hemoglobin is 8.8, MCV is low at 70. So a colonoscopy was performed, and it identified a fungating mass at the hepatic flexure, and a biopsy shows moderately invasive adenocarcinoma. Who here, let's open it up to discussion already. Anybody quibbling with what was done? This guy kind of moved straight to a colonoscopy.
Oh, can you repeat again the question?
Does anybody, what else would you have done for this 74-year-old gentleman who was having basically progressive fatigue and dyspnea, and his blood pressure was normal, physical exam was unremarkable? I think it's very important that these are totally non-specific symptoms, okay?
Yeah.
Shortness of breath and fatigue could be anything from hypothyroidism to a hypertensive urgency. So, these are very clean board questions, but to really round it out, to make it informative for your practice, I think certainly we see a patient like this. Hopefully we did get a CBC. Hopefully we got a comprehensive metabolic panel. Hopefully we got a thyroid function profile, quite frankly, because this could be hyper or hypothyroidism. But before we get to before we even get, let's block the colonoscopy out of it. This is a very, very clean presentation. I just like to round out the presentations, because life is never, at least my life is never this clean.
For me, I would say EGD, upper GI endoscopy.
Okay.
There are also some suggestions in the chat, as Christopher was saying, to complete the workup, the chest X-ray, EKG, iron studies, and TSH. And Nora also suggested that a microcytic anemia in a male patient would require some iron studies, and then she would think that a GI bleeding could be happening in this case, given the age, and then cancer until proven otherwise. Other people are suggesting, like Finn, we would like to know his baseline hemoglobin as well, to compare. And lady, I saw you unmuted yourself if you wanted to participate.
No, I think like someone has already mentioned EKG, because I was thinking more cardiology, like EKG and an echo, like a 74-year-old with increased shortness of breath. Like, yeah.
I would also add on one thing, in that they only mention really 2 lab values, right? But in a guy like this, I would kind of want to see, what are the other cell lines looking like? Does he have, what's going on with his white count? What's going on with the platelets? He could easily, he's at an age where you could have something like MDS. We don't know whether he's an alcoholic. I mean, there's a million different things that could also be going on. And obviously, I agree that most likely this is a GI source, but also things worth mentioning, I think.
I think this is absolutely crucial, and this is fantastic. I agree with you, because again, these are, these questions are done in a vacuum, and they are so clean, and they're designed. There's clearly learning objectives here that we haven't even gotten to, but my main learning objective is that we are all phenomenal internists, and internal medicine is much more a disease of evaluation, as well as management, whereas oncology is such a management related problem. Would anybody, so you get a guy like this, a 74-year-old guy with this 4 months, okay, and he's saying, listen, I'm more tired. I would just some clinical pearls here. What do you mean by that? How far? Quantify it. How many blocks could you walk a year ago? How many can you walk now? Are you shopping? Weight loss, weight loss, weight loss. Ask about it. Okay. Look at the belts. Okay. Guys, I don't know. Listen, I don't know if I'm allowed to say guys, women. For the most part, people who identify as men, I don't think we weigh each other. We weigh ourselves that much, and we might not know about weight loss, but we notice a belt or if clothes are starting to fit differently. So ask these questions. 100%, I think a CBC was in order. I would have added a TFTs. I always get B12, B12 deficiency. Certainly can happen in people who are drink a lot, even if they're not having signs of malabsorption. Same thing with iron deficiency can happen. And just as we get older, B12 deficiency can be a result of an autoimmune disorder, pernicious anemia. Same thing with thyroid dysfunction. So a CBC is easy enough to do. Yes, MDS can happen, acute leukemia can happen, CLL, CML. Somebody said something about an upper endoscopy. Fair enough. Always ask about black or bloody stools. It takes 2 seconds to do this. Any problem swallowing? Okay. Esophageal cancer often presents with a degree of dysphagia, often to solid foods, and people may start to modify their diet. Gastric cancer, early satiety, okay, or about an hour after eating, they vomit because of a gastric outlet obstruction. Esophageal obstructions, a high-grade esophageal obstruction, they're just going to regurgitate their food within minutes, okay? All of this makes very, very nice physiologic sense. It's fine to, at the time of getting a colonoscopy, also get an upper endoscopy, totally reasonable. Remember statistics. Colon cancer is about 150,000 cases in this country each year. Esophageal cancer, about, call it 15,000. Gastric cancer, call it 12, 15,000. So just from a statistical standpoint, if it's going to be a GI malignancy, that's leading to anemia. It's probably going to be a colon cancer, but fair enough. Go upstairs as well and check out the esophagus and the stomach. Small intestine cancers, fortunately, still fairly rare at about 3,000 cases a year. Moving on. Okay. So there's a cancer, and it's all the way. Okay, it's at the hepatic flexure. So it's a left-sided colon cancer. So we want to learn the objectives, rationale for the approach to staging colon cancer. We talked about a little bit about the clinical significance of colon versus rectal cancer and anal cancer, identification and management of partial small bowel obstruction, and eval and management of iron deficiency anemia. All right. So just things to think about when you get these questions. What would you do for this gentleman's minimally symptomatic iron deficiency anemia? And we're going to assume it's iron deficiency because it's microcytic. He certainly look at prior blood work going back years if you can. He could have a thalassemia in addition to an iron deficiency anemia. But let's say that is, he truly has iron deficiency. What would you want to do and why?
We can do A, which is a CT scan of the chest, abdomen, and pelvis. And the reason why it would be for staging to see if it's confined to the hepatic flexure, or if there is also metastasis in other organs like involvement.
Excellent. With this influence management, let's say that we see involvement of other organs.
Yes, it would, because if it's metastatic, then you're going to be going straight to chemotherapy rather than doing any surgical or another approach.
Correct. In all likelihood, that is 100% true. Do you want to do would anybody want to do a CT colonography? Would that help with surgical planning? Anyone? I'll take that as a no, or no CT colonography. Okay. The answer. What's that?
Sorry, I just want to say, I just see heads shaking. Maybe they just.
Oh, I'm sorry. I'm not that good technologically. I'm just, maybe I can open up the screen. I can't see you guys right now.
I'll let you know if.
All right. So listen, B, C, and D are not going to add anything for the vast majority of patients. Are you going to upstage anybody with a CT PET scan? Probably not. The degree of resolution with CT scans is pretty darn good. And keep in mind, you need a fairly reasonable cluster of cancer cells to light up on a PET scan. So for the most part, we never add PET scans to the preoperative workup or even for surveillance of resected colon cancer. So it's pretty straightforward that choices B, C, and D do not add to our management. And maybe the chiefs can share. I don't know if you already shared these questions with everyone, but I think it's just going to be painful to read through the answers. So can we skip
Share
that?
after the presentation.
What's that?
We can definitely share them with them afterwards. They
Okay.
don't have them.
Okay, got it. All right. And I promise you, we're going to go on with some additional slides that I created for entertainment and information. 69-year-old gentleman now is coming in, and he has a history of stage 3C disease, and it was removed 18 months ago. So stage 3C means there were 4 or more positive lymph nodes. He did receive postoperative chemotherapy, and he's been followed, quote, expectantly since that time. He doesn't take any medications. On examination, vital signs are normal. Examination is notable for a liver edge palpable 2 centimeters below the right costal margin. So you always lie the patient flat, knees bent, so the abdomen is nice and soft, and you certainly can begin to feel hard liver edges, firm liver edges. And the CEA is elevated. 70% of patients with metastatic disease will make a CEA. Another 40% may have a co-elevation of CA19-9. 8% will only have an elevated CA19-9. So it's okay to get a CA19-9, which is more of a marker for pancreas cancer. These markers are useful to not for initial diagnoses, but they certainly are helpful in surveillance. So because of these findings, a CT scan was appropriately performed, and it shows numerous hypodense lesions 4 centimeters in diameter in both the liver and the lungs. Prior postoperative CT scan results were normal. So let me just put it open to verbal responses. What do we think this guy's chances of relapse were after surgery alone for stage 3C colon cancer?
Hi.
Yeah, I mean, let's put it another way. What were the chances of him being cured with surgery alone?
No chance.
Yeah, very low.
It depends on how many lymph nodes he had. If he had, 8, 9, sometimes we see patients with more than a dozen positive lymph nodes, I think it's a virtual certainty that without surgery, they're going to relapse. It's getting, if it's just 4 lymph nodes, a T3, 4 or 5 lymph nodes, I think the possibility of relapse after surgery is probably on the order of 70%. With chemotherapy, we're probably getting him to about 50-50. You can think that we basically improve outcomes by about 33% with adjuvant chemotherapy across the board. And I'll explain. We can. Part of that is due to the efficacy of FOLFOX, which is the standard of care, FOLFOX or CAPOX, in eradicating minimal residual disease. And so that's a big problem. Now, of course, we don't want to treat 30, 40, 50, 70% of patients who are not already cured. So again, the TNM staging criteria or categories leave a lot to be desired with regard to treatment decisions. And again, this is where ctDNA is going to come in. So this guy had a very high risk of relapse. We know that we can, beyond chemotherapy, lifestyle can decrease the possibility of a metastatic recurrence. Being physically active to 18 metabolic units of activity per week, which is the equivalent of walking briskly, moderate exercise, 30 minutes a day, 5 days a week. This decreases the risk of relapse by in some studies up to an additional 50%. a healthy diet, no alcohol, tree nuts, avoidance of red meat also is helpful. Secondary prophylaxis with aspirin also may very well be helpful. So in my practice, I think in many other GI medical oncology practices, adjuvant aspirin is being recommended. Phase 3, this is from registrational data. It's robust. And as long as a patient doesn't have a prior history of gastritis, peptic ulcer disease, we can give aspirin. And I always say, you know, it's kind of, I know the recommendations for primary prevention of cardiovascular disease have been revised, but for secondary prophylaxis in a colon cancer survivor, aspirin is, I think, very reasonable pending further maturing data, which is looking at COX-2 inhibitors. I was going to say something else. When it comes to cancer prevention with aspirin, almost all of the benefit is with regard to preventing colon cancer. So there's fairly robust data. So anyway, this guy now has stage 4 relapse that in all likelihood is not going to be operable. So we always want to do surveillance for stage 2 and stage 3 survivors, because if we do regular CT scans in this country, we do every 12 months, we know that we can pick up metastatic recurrences when they're just oligo or few. Oligo means few, and we still may be able to cure those patients with oligometastatic disease that usually requires a combination of chemotherapy, possibly stereotactic radiation or surgery. But we know that this does extend survival in some patients. And the incidence of finding curable disease is about 12% with intensive surveillance versus only about 3% if you just wait for patients to develop symptoms. We talked about lifestyle recommendations. And again, in this gentleman, I don't think we're going to be able to cure him. Where are we? I don't think we're going to be able to cure him. But I think we can significantly extend his survival. So
just a question about the physical activity. That's very impressive numbers, so that it decreases it to 50%. What are the thoughts about the mechanism of physical activity decreasing?
Well, you know, so we don't know. One, there is intriguing data that exercise changes T cell metabolism, and that may impact on the tumor microenvironment, making our immune system more effective at containing minimal residual disease.
Interesting, thanks.
So the question here, this is really getting into subspecialty. This is really for medical oncologists. If it's on the mix-apps, it might be on your boards. What is the most important next diagnostic step to perform? Multi-gene sequencing of the tumor, needle biopsy to prove that this is a metastatic recurrence, a CT PET scan, or assess RAS mutation of the primary tumor.
I'm going to call on a third ear, Paulino.
I would say the RAS mutation of the primary tumor. However, I know the ASCO, and I may be completely wrong on that, but I think the ASCO now publish some guidelines for when to do multi-gene sequencing of the tumor. So I'm not sure whether A may be also correct now because I haven't read that paper, but for sure D will be correct.
You're correct, sir. Now, you're correct. However, we certainly need to reflect on this. In practice, we are not doing hotspot analysis where we're just looking at 60 genes. everybody is doing next generation sequencing of tumors, looking for certain somatic mutations. You can use the primary tumor to do this. We don't need to repeat a biopsy. We don't need to do a liquid tumor biopsy. The tumor needs to be sent, however, to any one of the approved laboratories for next generation sequencing. And one of the most, there are two pivotal issues. One, we want to see, actually, let me see one thing here. Okay, so this is a really nuanced question. Let me just get in. Is this too much detail, by the way? If you guys if I get into too much detail, just say basta, which I think is Italian for enough. Is that right?
That is correct, but everyone seems pretty interested just looking at where it takes us.
All right. So you're going to get next generation sequencing. Now, the reason Paulino, you were right, is yes, we want to know RAS mutation, because if he's KRAS and BRAF wild type, that definitely opens up the possibility of doing chemotherapy with a targeted an anti-EGFR monoclonal antibody. We would do that as a first palliative treatment for a left-sided tumor, okay, that is pan wild type, okay, is wild type for EGFR and for KRAS and BRAF mutations. However, there's a even more correct answer clinically. We need to know whether this patient has mismatch repair protein deficient or microsatellite unstable disease. Because if he is in the 5% of tumors, of patients with metastatic colorectal cancer that is microsatellite unstable, we do not start with chemotherapy, and we probably should not start even with an anti-EGFR monoclonal antibody if KRAS or BRAF wild. We want to start with immunotherapy. This is the one time in GI oncology where we know that sequencing matters. If you do not start with immunotherapy for these unresectable stage 4 patients, you cannot catch up and say, oh, well, on disease progression on chemotherapy, then we'll do nivolumab or pembrolizumab, which are two anti-PD-1 monoclonal antibodies. We have a randomized trial, I think it's the Keynote 177, that randomized patients to pembrolizumab or chemotherapy, and the survival curves separated fairly quickly. And despite the fact that there was crossover, patients who progressed on first-line chemotherapy could then get second-line immunotherapy. There was no catching up. The survival curves remain separated. So we start with immunotherapy. The fascinating thing about microsatellite instability and colorectal cancer is as we move, patients with stage 2 disease, 20% of them have microsatellite unstable tumors. 10% of patients with lymph node positive colorectal cancer have microsatellite unstable tumors. 4 or 5% with stage 4 disease have microsatellite unstable tumors. With combination nivolumab plus an anti-CTLA inhibitor, ipilimumab, the response rate is 65%. And these are durable responses. They can last, in some cases, years. So it's astonishing. Why is there this difficulty? Why can stage 2 tumors not migrate to stage 3? Why is it so difficult for a stage 3 that's microsatellite unstable to migrate to stage 4? I think the story really is with our immune system, and it's an extraordinary story. What about just treating stage 2 and stage 3 disease with adjuvant PD-1 inhibition? We are testing that hypothesis. What is fascinating to me is Sloan Kettering just published or presented at this year's GI ASCO, which happens every February, small pilot trial looking just at nivolumab as neoadjuvant therapy for microsatellite unstable rectal cancer. Now, microsatellite instability is more rare on left-sided colon cancers and rectal cancer as opposed to right-sided. So you're starting to get a feel here, or I'm introducing the idea that laterality, in terms of cancer medicine and tumor biology, right-sided tumors behave differently than left-sided tumors. Nevertheless, for patients with rectal cancer treated with neoadjuvant preoperative nivolumab, the complete response rate was 100%. Now, this is a small trial of 11 patients, but this is extraordinarily robust data. Anecdotally, I can tell you, I had a woman who had a diagnostic colonoscopy and at an outside system, and she perforated, so she couldn't have her right-sided colon cancer treated right away. So as a bridge, we gave her nivolumab. Same thing happened when they went to. She was operated on in the system, and you know, it was one of those situations where then there was the postoperative freak out because the colon where we knew the tumor was completely normal. It wasn't even scar tissue like we see after chemoradiation. It was just normal mucosa. So the first concern was that that there was a clerical error and this, the patient never had cancer or the wrong part of the colon was operated on. But no, the reality is this medicine is really, really effective. So immunotherapy is super effective in microsatellite unstable tumors. "42-year-old. So this is half our tumor boards are people in their 30s and 40s with colorectal cancer. So she had stage 2 disease diagnosed when she was 39. Her tumor was found to be mismatch repair protein deficient. MLH1 was absent. Classically, you have pairs. The four major mismatch repair proteins, typically, if there's going to be loss of them, either from germline loss or epigenetic silencing, which is the much more common way in which we lose overexpression of MLH1 and PMS2. Classically, you lose a pair, and MLH1 is paired with PMS2. So she had an actual genetic evaluation which showed Lynch syndrome, which again is a germline mutation which predisposes young people to cancers. The classic cancers are colorectal cancers and then endometrial cancer, but you certainly can get, typically they're benign, but you can get gastric polyps. You can get cancer really you can get bladder cancers, urothelial tumors of other parts of the GU system, cholangiocarcinomas. So she developed recurrent disease 9 months later, they're saying. So I don't know if this was. Anyway, she developed recurrent disease and she has a KRAS mutation, and she was inappropriately treated with 5-FU and oxaliplatin Folfox, progressed, then she got irinotecan, and there was only a short duration of tumor control but before she relapsed. She's an excellent performance status of 100, meaning she's able to work full time. So on physical exam, nothing is abnormal. So is she hospice appropriate, or should we talk about clinical trials or other standard of care options? She's been through 2 different lines of chemotherapy and her disease is primary refractory. It blows right through chemotherapy.
Trials? I mean, she's still young and physically active.
Right. So trials would be an option. What sort of standard of care might be an option for her?
Immunotherapy?
Absolutely. This disease really needs to be thought of as just really an immunotherapy deficient state. So one, she has an excellent performance status, even though she has a chemotherapy resistant tumor. I think that we can do, she has a major opportunity with immunotherapy and then potentially at some point, clinical trials. My bias would be we've got immunotherapy available. Classically, we think nivolumab plus ipilimumab has about a 65% response rate. I'm not thrilled that we may have perturbed her immune system already with chemotherapy, but so be it. Understand the differences and similarities between mismatched protein repair deficiency and microsatellite instability. Does anybody want to take a crack at that?
I know a little bit about the basics. I know both mechanisms are related. Microsatellite instability refers to nucleotide strep additions that are in the ends of the chromosomes, and that can be mutated in cancer, and can mean that patients are more susceptible to immunotherapy. And mismatch repair protein deficiency is the mechanism that we use to repair mutations in our DNA. So if there's deficiency in that mechanism, we are also prone to develop mutations. So that's something. Yeah.
So that's fairly correct. I think that really all patients who truly have mismatch repair protein deficient tumors of any organ system, their disease by definition will be microsatellite unstable. Mismatch repair protein, this really, the similarities are overwhelming, and the difference really is a difference in way it's a testing difference. So identifying a patient with a mismatch protein repair deficient tumor, it's an immunohistochemical study. So these are stains that are read out by pathologists, positive, weakly positive, or negative. And that's the rub. There can be human error, there can be inter and even intra-observer variability. Whereas microsatellite instability it can be identified through next generation sequencing, and it's much more secure. We wouldn't want to think a patient is mismatch repair protein deficient and then see that they're microsatellite stable, having given them immunotherapy already. I won't necessarily wait for next generation sequencing results, but I always double check and get my microsatellite instability readout from next generation sequencing. If I already know that the patient is microsatellite unstable, I don't need to check mismatch repair protein deficiency. They should be mismatch repair protein deficient. And if they're not, I will interpret the microsatellite instability yet mismatch repair protein expression as my interpretation will be that this patient has some other mismatch repair proteins which are deficient. So microsatellite instability is a next generation sequencing test. These patients almost always have a fairly high mutational burden per megabase. Really the importance here for either one of these tests is that these patients are vulnerable. Their tumors are very, very vulnerable to immunotherapy. And again, it does not matter what tumor type you have. If you have microsatellite instability, your metastatic disease is likely to have very, very lasting benefit from immunotherapy. And our immunotherapies, in fact, are approved for patients simply with microsatellite unstable cancer, irrespective of site of origin. So it's site agnostic. It's a very, very specific molecular indication. And then, of course, a KRAS or BRAF mutation means you cannot get an anti-EGFR monoclonal antibody, certainly if you're KRAS mutated. If you're BRAF V600E mutation, which is the vast majority of BRAF mutations, then we can sensitize your tumor to anti-EGFR monoclonal antibodies by combining the monoclonal antibody with a BRAF inhibitor. Either of those agents alone, the antibody alone or the BRAF inhibitor alone in V600E mutated colorectal cancer, forget it, no efficacy. So this woman, I think we're all good with, we're not going to offer her D, which is hospice for all intents and purposes. EGFR monoclonal antibody, nope, she's KRAS mutated. An immune checkpoint inhibitor, that's not unreasonable. What's choice C? Dual antibody therapy. Oh, with VEGF and an endothelial growth factor receptor. That's a, yeah. So B, I don't even understand choice C. And I would not do pembrolizumab alone in this woman. I would do Nivo plus IPI. We're gonna move, I know it's super late. I just wanted to get to one question here because I think it comes up a lot. Oh, let me show you this. Can I go on for 2 seconds?
Sure, absolutely.
All right, look at this. This is amazing to me. So in stage lymph node negative colon cancer, particularly T3, not T4, but T3 N0 colon cancer, the chance of you being cured with surgery alone is about 75%. If I give you postoperative capecitabine, which is an oral form of 5-fluorouracil, 75% goes to about 78%. Meaning I got to treat a lot of patients who've already been cured to save a small cadre of patients who have minimal residual disease, destined to relapse, that is also sensitive to the chemotherapy. So we need to do better. So one way to do better is to already really enrich the patient population that is destined to relapse. And it looks like that opportunity is on us. This slide, this data has been confirmed in many other data sets. This is a slide from ASCO 2017. We've known about this data since about 2015 now. Postoperative ctDNA, or ctDNA should last in our bloodstream a few hours. ctDNA, the techniques to do this, to get all the other circulating DNA fragments in our bloodstream from normal cells, from normal bodily metabolism, we can now very sensitively and very specifically identify tumor DNA. It only lasts in the bloodstream a few hours, so it is going to be a very useful prognosticator for patients with resected stage 2 and stage 3 and even stage 1 colon cancer. If you are positive, if you have postoperative positive ctDNA, which again is only in stage 2 disease, only about 8% of patients, you are going to relapse, okay? On the left is stage 2 disease, it's 100%. Whereas if you are ctDNA negative postoperatively, the chance of you staying cured is about 90%. Stage 3, same thing, okay? In this data set, it's 16% of patients are going to be ctDNA positive. They will all go on to relapse, okay? We need, the hypothesis then is, what if we just look at patients with postoperative ctDNA and we offer them chemotherapy? Now, this is being tested here at Sinai, as well as many institutions across the country. The trial design is pretty intuitive. Patients who have stage 2A disease and whose physicians are in equipoise, we're comfortable with patients not getting treated, or we're comfortable with them getting treated if they have ctDNA positivity, they will get randomized. So arm 1, your ctDNA is collected postoperatively and everybody is blind to it. It's batched and the code is broken after the trial is done. Arm 2, we know what's going on. If you're ctDNA positive, which there's about an 8% possibility that you will be positive, then you will go on to get postoperative FOLFOX. There is a minuscule amount of data. That's not no data, but there's a minuscule amount of data that we can clear ctDNA. And if we clear ctDNA with postoperative chemotherapy, your survival outcomes are better. We don't have 5-year survival data. We don't have 3-year survival data. We have 12-month disease-free survival data. So this trial is still ethical, and it was just opened last week here at in our system. The holy grail here is, can we just do blood tests now looking for a host of cancers? The quick answer is I'm not so sure. We will learn. There is a platform from Garden Technology looking at this, but you see here the sensitivity for stage 1 disease is only about 43%. We really want to be able to detect polyps and snip out polyps before they become cancerous. Stage 1 gastric cancer, 13% of patients will have ctDNA circulating. Once you get into higher stages of disease, though, you see here how incredibly well ctDNA can perform. I don't know that it will become a screening test. It certainly is not ready to be a screening test for a pan-tumor screening test in 2022. I've had Lynch patients ask me this. We're just not there yet. Should it guide postoperative chemotherapy? No, it's a research question. I just described one of our research trials. Let your imagination go wild as we can quantify ctDNA, certainly as an early biomarker of response. We can learn a lot more about the efficacy of interventions, whether those interventions are new drugs or even lifestyle interventions. Clearance of ctDNA good, persistence or increase in ctDNA bad. So I didn't list it here, but even in the adjuvant setting, if you start to secrete ctDNA, there's a trial looking at these lifestyle recommendations that we talked about. Exercise. Can you potentially exercise your way out of a positive ctDNA? So this is minimal residual disease, 1 out of 10,000 cells being able to be detected, now available for solid tumors. This is where we've been at in malignant hematology for really the past 20 years or so. We just didn't have the technology. I'm just going to say, I know I'm way over time. If you have a patient who's coming in with post-chemotherapy, nausea and vomiting, think about whether you've made a diagnosis of breakthrough CINV, okay? That typically is going to happen. It's going to be ongoing CINV, chemo-induced nausea and vomiting, or even just loss of appetite within 72 to 96 hours of getting chemotherapy. The vast majority of our patients are not getting ondansetron anymore, okay? In our infusion suite, primary prophylaxis is with a 3rd generation 5-HT3 antagonist. Think Zofran to the 100th, okay? It's palinesitron, and it has 5-HT3 activity for about 5 days. So if a patient still is coming to you with ongoing nausea and vomiting, giving them Zofran, if they got palinesitron 3 or 4 days before, ain't gonna do anything. You need to start thinking about medicine. First of all, make sure that you're not dealing with a bowel obstruction. Make sure that you're not dealing with brain metastases, particularly if it's breast, renal cell, lung cancer. But think about, in addition to hydration, the mainstay of treatment of breakthrough nausea and vomiting is olanzapine, not compazine anymore. We have multiple randomized phase 3 trials showing the superiority of olanzapine versus compazine or metoclopramide and benzodiazepines. So it is, as an attending once told me, I think it's a sort of a coarse way to describe things. It is better to sleep than to puke. Again, you're not seeing a lot of patients with breakthrough nausea and vomiting. I would probably say it's quite possible none of you have admitted a patient or seen a patient in the emergency room with breakthrough nausea and vomiting, because it just doesn't happen anymore. We're so good at, first of all, it happens in about 10% of patients. And if it does happen, we're already prescribing olanzapine and benzodiazepine. So it should be a very, very exceptional patient that's coming in with CINV, with breakthrough CINV. That's it. That's all I wanted to get off my chest.
Thank you so much, Dr. Kozuch. That was fantastic. I don't know if there are any questions, but if that's okay, you can email those questions to you.
Absolutely.
Thank you again for your time.
Or become oncologists.
That's another option. I think a few of our residents have already picked that option. So guys, thank you again. Dr. Rothman, I see that you're on. Oh, and Dr. Kozuch, thank you again, and hope that you have a fantastic rest of your afternoon.
All right. Bye, guys.
Goodbye.